electrocardiogram. You know that those are manifestations of hyperkalemia, and we are dealing with hypokalemia. So no. Uh, Decrease deep tendon reflection. This mean in English, you don't, in the real English, you don't have those acronyms or abbreviations without being explained previously what meant. Okay, so you have deep tendon reflex parenthesis DTR. Uh, yes, the hypokalemia produces muscle weakness and decrease deep tendon reflexes. So it's important that has muscular uh, repercussions, and it is mainly muscle weakness and decreased deep tendon reflexes. ST depression on the EKG, yes, the hypokalemia is one of the causes of depression of the ST segment. The, the ST segment can have depression, no? So can have a depression, a depression. So it is, yes. Uh, Irregular pulses. Okay, this is difficult to interpret, but theoretically, hypokalemia is the cause of cardiac dysrhythmias, and the cardiac dysrhythmias produce irregular pulses. So the most logical is to say that yes, but let's see. Remember that those are questions that don't have answer key. It's like if we were in the actual English. Flaccid muscle. Flaccidity is the same as weakness. I meant it is when the muscle cannot contract and the muscle tone is decreased. So yes, the same as U wave on the electrocardiogram. You know that after this depression can appear an abnormal extra wave, which is the U wave. And so yes, and constipation. The hypokalemia produces decreased peristalsis, and the decreased peristalsis can manifest as constipation. So it is true. So take care with this detail, because sometimes there are questions that say, for example, the patients had surgery 2 days ago and the bowel sounds have not yet returned. What is important for the nurse to check to find why the bowel sounds has not returned? Check electrolytes for hypokalemia. Could be a question. Another question: the client is treated with potassium, intravenous potassium or oral potassium, because previous hypokalemia, which finding tells the nurse that the treatment looks to be working, and the answer is the client doesn't have any more constipation. The client is going to the bathroom every day. So yes, they use constipation in English. I have proof of that. Uh, uh, they use constipation in English as one of the manifestations of hypokalemia. So except the first, all the others are correct. It's just a practice question. You know that cerebral applied questions don't require too much thinking, or you don't know each item. Any doubt? Okay. The next question that we have here says, the nurse administers the morning dose of a rapid acting insulin. Okay, you know that when they say rapid acting insulin, they refers to Lispro or to Aspart. The other is that the leucine, but it is rarely used. So Lispro and Aspart are the most important. Okay, when they say rapid acting insulin, I always confuse rapid acting insulin with short acting insulin. Short acting, short acting is the regular insulin, while the rapid acting is the Lispro and Aspart. But I always confuse these two stuff. I need to be very careful when I'm reading of not confusing that. So it is really rapid acting insulin, an insulin that they start working very soon, and the peak of action is in between 1 to 2 hours. It's very quickly acting. The nurse administered the morning dose of rapid acting insulin, lisproaspart, to a type 1 diabetes mellitus 38 years old client. 2 hours later, the client is observed profusely diaphoretic, sweating, and confused. So the brain is having malfunction, is confused. What must the nurse do first? This is a word that makes the question difficult. And I'm not tired of insisting when you see in a test this word first, next, most important, primordial, I don't know, uh, a question of what is the most important, the prioritization. You know, it is a difficult question. So take the question slowly. Don't precipitate to answer the question. What you do first? It is asking me for a chronological priority. So everything could be correct, but one is the first to be done. This is a problem that I see frequently as an educator at the moment of my student answering questions. They don't respect this word that is a command. So I have administered half a cup of orange juice or regular soda. This is 4 ounces. No, half a cup is 4 ounces. 4 ounces. Um, Regular soda means no diet soda. Obtains blood glucose level. Says if the client didn't eat his breakfast, and administers glucagon intramuscularly. So it's a tricky question if you are in a rush, because we are conditioned that a client after receiving insulin could could present hypoglycemia and diaphoresis and altered mental status, confusion, alteration of the brain function are manifestation of hypoglycemia. Nevertheless, the diaphoresis and the altered mental status are not exclusive manifestations of hypoglycemia, can be also the manifestation of other conditions. So here we don't have a glucose level to confirm that this client is having hypoglycemia. So we need the blood glucose level, which is easily determined with a capillary blood sugar with an accurate check. And this is necessary, is demanded in good practice, in good nursing practice, before deciding that the client has hypoglycemia. So we cannot assure that the client is having hypoglycemia until we do the accurate check. The capillary blood sugar takes less than 1 minute to practice. It's a very rapid test. Nothing is going to happen in these 1, 2, 3, 4, 5 minutes that we delay the administration of orange juice to a client, for example, um, um, while we determine the blood sugar. So the right answer of these questions is C, do the assessment necessary to confirm objectively what we suspect that the client is having hypoglycemia. Once we confirm that the client is having hypoglycemia, which means a capillary blood sugar less than 70 milligrams per deciliters, then we determine if the client is conscious enough as to administer a dose of oral sugar, or if the client is not conscious enough as to avoid potential aspiration, and then we administer either glucagon intramuscular or the 50W intravenous, depending of what we have or the situation. So the answer of this question must be C. And it's a question that if you are one of those students that rush and don't read all the options and consider, more than reading, consider all the options, you could commit the mistake of selecting A. Some could select D, okay? And even some could select C, which is not helping at all, because independently of the fact that if the client had or had not the breakfast, the client is having symptoms suggestive of hypoglycemia. Okay, so take care with this kind of question, which is very anxious. Very anxious. I saw this with a newborn son of a diabetic mother. We are conditioned that children of diabetic mothers have predisposition of developing neonatal hypoglycemia, which need to be, evaluated and corrected if necessary. And the answer of that question was in English was the same. What do you do first? You do the ACU check to verify that the jitteriness or whatever we suspect in the child that could be a manifestation of hypoglycemia is a real hypoglycemia. Okay, so sounds like a silly question, but it's a question that you cannot fail. You cannot afford. Okay, you cannot afford failing this question in your English. It's important.
I,
Okay.
I, I was going to choose check the blood glucose.
Okay. So this is the correct. This is the correct.
Oh, the blood glucose is the correct one.
This is the correct.
Okay, thank you.
First, Marie, confirm that what you suspect is the real. Marie, if you see your boyfriend or your husband in, in something that you suspect that could be cheating on you, do you immediately, present to him the divorce?
No,
No.
I heard
You
you say
first check
access.
the phone.
Yeah, that.
First you check, you could be a detective, okay?
Yeah,
You
I was
find
ready.
the evidence, Marie. First you need
Yeah,
to find the evidence, yes?
no, I was
Okay.
confused. I heard you say access.
Okay. So the problem here, Marie, that you are suspecting hypoglycemia and is a valid suspicion. But you
Yeah.
need to confirm that. And they are asking what you do first. And what you do first is to verify that this is a hypoglycemia. So the
Okay.
first is to do the acute check. And then after doing the acute check, you decide if you give the orange juice, if the client is conscious enough as to tolerate the oral via, and or if the client is not, you then could decide administer the glucagon. Okay.
Thank you.
The other way that Marie I used to convince the student that this is the right answer is when the client that is diabetic has a myocardial infarction. This is too young for a myocardial infarction, but it could be. Frequent, not always, but frequently, clients that are diabetics suffer myocardial infarction without pain or with atypical symptoms. So the chest pain that makes everybody think in myocardial infarction could not be present in diabetic clients. Nevertheless, as manifestation of the myocardial infarction, especially in older people, there is a lot of sweating, there is a profuse diaphoresis and altered mental status as a manifestation of myocardial infarction. And can be confused. The symptoms can be similar. And my question is always, do you treat myocardial infarctions with orange juice? So this is another way that when I have time to explain why this is the correct first to verify objectively, precise objectively, but you suspect clinically with if it is possible quickly to be verified with something so simple as an acute check. Why is the priority? What you need to do that first? As is a sarcastic way of making you accept that this is a correct behavior verified what you are suspecting, if it is possible, of course. In this case, it's easily possible to be verified because with a simple IQ check or capillary blood sugar, you can verify that. 28 hours after abdominal surgery, a client tells the nurse, that the wound feels opened. So the client is telling the nurse, my wound feels open while he was ambulating. So there is a possibility of having a dehiscence or even an evisceration in this client. Is a possibility. And then I have another question, one after other, that is in some ways similar. What would the nurse do next? In this case, the word is next instead of first. But for test purposes, at least from my point of view, they are synonyms. They are the same. First and next is the same. So you can exchange next for first, and it's the same meaning. What you do first, what you do next. And then you have asked another nurse to call the surgeon. It could be a right intervention if the client has a dehiscence or evisceration, especially if there is a evisceration, but either one. Notice that there is a difference between dehiscence and evisceration. The evisceration is much more severe than the dehiscence. The dehiscence is when there is just separation of the skin, the subcutaneous. Meanwhile, the muscular plane is kept joined by the stitches, and the viscera, the intestinal loops are not protruding. While evisceration is when the muscle level give way to the pressure, and the intestinal loops are protruding. Okay, B covers the wound with moist, sterile gauze. This is something that we have been memorizing. That is a correct intervention and sounds very attractive to us. So it's absolutely correct, the same as it is correct to call the doctor. But they are asking not what is correct, but what you do first. And then I have check. The nurse checks the operative site. So what is this? An assessment of the site. And then the last is instruct the client to flex the legs and avoid coughing. You make the patient lay down. You don't elevate the head of the bed. You only put a little pillow there, okay? A small pillow there. And then you ask the client with the dehiscent to slightly flex the lower extremities and to stay quiet, relax there in bed, okay? And avoid increasing the pressure in the abdomen, because if the client is talking, the client is screaming, if the client is coughing, etc., you increase the pressure in the abdomen, and the stuff is going to be pushed out, no, even more. That's why it is also correct. Okay, so it is also correct. So all the interventions are correct, but they are asking not which one is the correct, what you do first. Obviously, you are basing your interventions in the statement of the client. Who is the person that is most authorized to make a diagnosis of dehiscence or evisceration? The client or the nurse? So the nurse, the client tells the nurse what he or she thinks. The nurse must go and verify that it is what is happening and then take the decision of the others. So the answer here is again assessment. No, the interventions that we know are correct, but they are not asking what is correct. They are asking what goes first. So it's the same lesson. It is this question of first and next is are not exploring so much knowledge, but common sense. If we can make a hierarchy of priorities, that from the point of view of chronology, time, what goes first, what goes seconds, etc. In this case, the first should be verify that is the dehiscence, then make the patient lay down, relax with the legs flex, then cover the the opening with the sterile moist gauze, and then okay communicate with the doctor to decide what he's going to do. If it is a visceration, prepare for surgery. It is a dehiscence of only the skin. I can tell you that frequently they leave this open. They don't because it's because it's infected, because the client has too much inflammation and too much tension, and then the doctors prefer to leave this open when it's only the skin until the inflammation and the pressure subsides, and then make a third intention uh, uh, reattachment is variable. So again, this is the Nclex style question that can confuse us. If we memorize without thinking the answers that we had in our classes, in our test, that cover the wound with that, call the doctor for surgery, make the patient lay down, we lose the question because the first is to verify that the client has a real dehiscence because everything is based in what the client said, and the client is not the most prepared or trained or authorized person to diagnose that a dehiscence is happening. The nurse is doing triage on polytraumatized clients at an industrial accident. So it is on the field. It's not in the hospital. Okay, it is a triage on the field. Okay, the nurse finds a client with a penetrating wound in the chest, which makes a sucking sound each time the client breathes in. Which of the following nurses' interventions is best? Okay, it is again making the question difficult because now you need to decide which one is the best. Okay, now it's not chronological, but in quality. What is the best intervention in this situation? So you need to understand the situation. Uh, in the thoracic cavity, you have an space for the lung, and this space is covered by the chest wall. Now there is a communication, a penetrating wound that obviously make the air of the environment communicate with the pleural negative pressure of this this lung. And each time the patient breathes in, when the patient breathes in, the clients create a sucking pressure, a negative pressure, like a vacuum, to suck the air through the trachea. All we do that each time we breathe in, we create a negative pressure in our thorax, and this is what makes the air enters through the trachea to the lungs. But now that they have this communication with the chest wall, also through the wound, air is entering, and each time the patient breathes in, air enters in the pleural cavity. And you know that each time the patient breathes in, more air enters. And breathe in, more air, breathe in, more air, breathe in, more air, breathe in, more air. And the problem is that a simple, uncomplicated pneumothorax can become in something worse, in a tension pneumothorax. So you need to have very clear that it's not the same. It isn't the same. Pneumothorax versus tension pneumothorax. Tension pneumothorax is a life-threatening condition. Pneumothorax is an urgency that requires okay attention, but it's not an immediate threat for the client's life. But tension pneumothorax, when the pressure inside the pleural cavity is so high because so much air has already entered there that the heart is pushed together with the aorta toward the other side of the thorax through the good lung, squeezing the good lung and twisting the heart and the aorta. This is what kills the client because the twisting of the aorta and the heart producing an obstruction of the blood flow. The normal blood flow that should be flowing through the heart and the aorta, when it's twisted, is going to produce an obstruction. So an obstructive shock develops when there is tension pneumothorax. So, summarizing, what you need to understand as a nurse in this emergency situation in which you don't have yet resources, you are on the field, what is the most important to avoid a pneumothorax that is already happening here? There is a simple pneumothorax, nothing else is described. To prevent this pneumothorax converting, evolving to a tension pneumothorax, you cannot allow more air to enter. So let's see the options. Initiate a peripheral venous device with a bead gauge catheter. It is necessary, but it's not the most important. It is not going to prevent that air continues entering in the pleural cavity. Initiate oxygen through nasal cannula to 3 liters per minute. It is important, but it's not the most important. The most important is to prevent air from entering, okay, beyond this moment and preventing the builds up of pressure inside the pleural cavity. And then you have press on the wound with a gloved hand until help arrive. It sounds good. Why? Because you are placing on the hole through which the air is entering, you are placing your hand covering the wound and preventing the air from entering anymore. And the last is transfer the client to the ER as soon as possible is correct, but there is not what you can do in this moment. You cannot wait for the ambulance to arrive and the clients to be transported to that to prevent that. So you need to close this hole to prevent more air from entering. So this is the best answer to this question. This is a variation of the classical question in which this is happening in the emergency department. The client is arriving into the emergency department where we have all kind of resources, and we can find a non-porous, no, a impermeable gauze or dressing, and we can place over the hole, over the wound, we can place this dressing, okay, over this, and we are going to tape only 3 sides, only 3 sides, because it is going to prevent the air from entering. The air cannot enter because when the patient breathes in, the non-porous gauze is going to stick or attach to the hole, preventing the air from entering. But when the patient breathes out, if some air can live through the hole, can be leading through the non-taped portion. But this is another intervention. It's not mentioned here. So can you have in your anchors variations of the same concept? Yes. And this is an example. Okay. Why? Because it is in a field where the only thing that you have is your hand and gloves, nothing else. And then this is what you're going to do, because the important is to prevent more air from entering in the pleural cavity, adding pressure that transforms a simple pneumothorax in tension pneumothorax, because the tension pneumothorax is what kills the client. It's not the pneumothorax. Pneumothorax don't kill unless they become tension pneumothorax. And this is a concept that you need to master to be able to answer this kind of question. The nurse is evaluating the tissue delivered to the mother of a 7-month-old male infant, an infant. Which statement indicated the mother understood the teaching? So we are looking for the correct statement. I will always lay him with back up. This means that the back is up, so the client will be in prone position, and we know that it is incorrect. we should avoid, okay, while the baby is in bed or in the crib, okay, we should avoid the prone position and the lateral position. The baby should be all time supine with the back down. So this is incorrect. It promotes sudden infant death syndrome. I want to give him beef, chicken, and cheese one each week. It sounds correct because it's already 7 months. And after 4 to 6 months, we can start introducing solid food, and beef, chicken, and cheese are allowed in the first year of life, with the precaution of giving one by one each week. So if there is any kind of reaction, we can detect which food is producing the reaction. I like it. So probably this is the correct understanding. I will put in his crib, okay, rattles, cubes, and bright colors balls to play. The theory says that we should leave the crib totally empty. Only the baby with firm mattress, a fitting sheet, and nothing else. So it is not correct. It is um, cluttering down the crib with stuff that can suffocate the child. I will introduce rice cereal. Rice cereal is okay, but says that with 2% milk. 2% milk is cow milk, and babies less than 1 year cannot have cow milk. So it is incorrect. So the right answer is this. So if we have this kind of question, our anchors, we happy because it's an easy one. It's an easy one. It's very difficult that you fail this question. The nurse making rounds with the physician notices that he or she didn't sanitize the hands before and after examining clients. Okay, it is not rare from happening. Okay, even you can see that in nurses, etc., CNAs. Which nurse intervention best? Again, this word makes the question difficult because maybe the interventions are good, but you need to find which is the most good, the best, and which nurse intervention define the concept of non-maleficence. So what means non-maleficent? Don't harm, okay? Don't produce harm to the client. This is the concept of non-maleficence, okay? Whatever you do or you don't do is to avoid harming the client. So let's see. And they are asking the best. Discuss in private this behavior with the physician after the round. So notice that if you do that, which is okay, but it is after the round, so the harm was already done. So I don't like it for that reason. The client already received the bacteria that were in the hand of the physician. Post a sign reminding hand washing on every room's door. Okay, it is like a suggestion and indirect for the physician. Okay, but again, is going to be a short intervention that is going to make the physician sanitize the hands before touching the client. Is it happening? So makes me have doubt. But then there is something more proactive. Carry a bottle of alcohol, hand sanitizer, and offer it, present it to the physician before and after each client contact. So it sounds much more proactive and is more probable, much more probable that this intervention will prevent the bacteria of the hands going to the client because alcohol is going to sanitize the hands. So sounds much more efficient, more proactive than just posting signs to see if the physician gets the indirect, or if especially that you are going to post signs after the round has finished. Yeah, because you are making the round in that moment, and is when you notice uh, uh, the problem. So I like this more than B. And the last says report the physician to the hospital infection control committee. Okay, probably is necessary, but it's not going to prevent the harm because the physician already touched the client with dirty hands. So the one that is preventing the harm, preventing the contamination of the clients, the best option, I think, is C. Notice that those questions are not knowledge questions, are common sense questions. Of course, you need to have some knowledge. You need to know what is non-maleficent. You need to have the knowledge that alcohol hand sanitizer is the same as washing the hands, etc., etc. So some knowledge need to be known. Which of the following clients has the highest risk of contracting hepatitis A? So you need to remember that hepatitis A is a fecal oral. And fecal means that particles of feces with the virus of a carrier, okay, could be contaminating under the nails, food, etc. We can ingest that. This is the way that we could acquire hepatitis A. Of course, if we are vaccinated, it's not important this situation because even if we consume food or beverages that are microscopically contaminated with particles, fecal particles, uh, it's not going to harm us in relation with hepatitis A. But there are people that are not vaccinated. Okay, there are people that are not vaccinated. You know that there are children having measles because are not vaccinated. The same way that hepatitis A, which is not a mandatory vaccine in the schools. So the question is, who of these four clients has the highest risk of catching hepatitis A? Hepatitis A is rare in the United States. First, because it's a very clean country. Sanitation is enforced. And second, because a grand part of the population is immunized, and the herd immunity is protecting others. That's why it's not frequent. But hepatitis A is a hepatitis. This is that when it's seen here in the United States, it's seen mainly in young people. In young people. Okay. Um, so diabetic clients who share the same blood monitoring machine. Sharing the same AccuCheck machine could be a source of contamination of blood. And blood is important for blood-borne pathogen, for hepatitis B, for hepatitis C, and for hepatitis D, that are the blood-borne pathogens related hepatitis. So we can rule out this because we're talking about hepatitis A. The same for the hemodialysis unit. The hemodialysis unit, there is an abundance of blood that favors the possibility of a mistake, okay, a failure in the standard precaution that could produce a contamination. And it is important for hepatitis B, C, and D, but not for hepatitis A. That's why we rule out these two options that are true, are real, but for hepatitis B, C, and D, not for hepatitis A. So now we have a client who consumes fish, sushi, shrimps 3 times per week, and a teacher who works with a daycare with preschool toddlers. The important here is to know that many of the preschool toddlers are still diapered, are still not potty trained. And then feces are abundant, are abundant. Incontinence are prevalent. And we know that raw, raw shellfish, okay, raw shellfish could could also be a source of hepatitis A. So we have these two options. We need to decide. So notice that here they are talking about fish, which is not shellfish. Sushi, that generally is a tuna, is a fish stuff, and shrimps that usually are consumed cooked. The raw shellfish are mainly the oysters, is the most common source of outbreaks of hepatitis. That is not frequent, it's rare. Okay, oysters is a risk, because are consumed raw and are the real shellfish that can be contaminated with the virus. So if I need to decide between this and this, I think, because it's a question, this is a question that I wrote based in what somebody had in in his test. And I think that the one that has the highest risk is the one that is dealing with feces with frequency, because one of those toddlers could be, carrying the virus and could be shedding the virus in the feces, and this could contaminate an unvaccinated, okay, caregiver or teacher. So this is uh, 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 my defense of why I should be choosing this if I were having this question in my test. Which emergency department client cannot be allowed to sign against medical advice discharge? So which of these clients is a select that apply? Which of these clients cannot be allowed by you, the nurse in charge of this shift, to leave the facility against medical advice, signing against medical advice? So the against medical advice is when the client leave the facility, which is a right of the majority of the clients, leave the facility without the consent or the recommendation of the physician, because it still is not ready to be discharged. But it happens. And by law, clients that are in the majority of age, so they are not children, and clients that are in their adequate mental mind, okay, mental status, have the right, the legal right, to live against medical advice without any kind of punishment or consequences. But the requirement is to be adult and to be in his or her mental capacities. And of course, being in their mental capacity is not being hospitalized against the client's will, not to be committed. What you call Baker Act in the test is called commitment. So involuntary commitment is what you call Baker Act. Baker Act is only in Florida, and the test comes for all the states, it's federal. So you are not going to have Baker Act. You are going to be involuntary, also no voluntary commitment. Okay, it is the word used when the client is a risk for himself or herself, and, or a risk for others. In that cases, they are, hospitalized against the client's will. In that case, the clients cannot live against medical advice in this rare condition. Okay. So now that we clarify the theory, an 18-year-old is adult. Sickle cell crisis, so is having a vaso-occlusive crisis of sickle cell disease with hemolysis and pain, receiving oxygen and hydration. Okay, this client is in his or her mental capacity and is adult, can live. And we are looking for those who cannot be allowed. This can live if wanting. Client who drank 1 bottle of vodka an hour ago, so he's drunk, he's intoxicated, and presents hypoglycemia. So the brain of this client is not in the capacity of taking decision. So we cannot allow a drunk client, a client that is out of his or her mind, to live against medical advice because is is a safety issue that we cannot allow the client to live. So this client cannot live until recovering of the alcohol intoxication and from the hypoglycemia. The brain is not in capacity of taking this decision. We cannot allow this client to live.
One quick question,
Sure.
Professor. What if that client has a proxy and the proxy want the client to get out of the hospital? Or can we stop the proxy?
A client that has what?
A proxy,
Epoxy.
a somebody who can take decision for him.
Oh, a proxy. Okay, a proxy. Yes, but it's not mentioned here. If if you want to write the question, okay, uh, you can introduce this element, which is going to make the question more difficult. Okay, I accept that, but it's not stated here. Is a client the one that can or not or cannot sign for for living again medical advice. Okay, so don't introduce an element that is not in the question. If the client has a proxy and the proxy has a durable powers of attorney and assume responsibility of the client legally, theoretically, legally, the uh, durable power of attorney could assume the responsibility of the client and sign for the client. But this is so complicated. Remember that my mind is centered in Nclex. My mind is not centered in the real life situations. Because the real life situation, you are going to learn that when you get your license. And you are going to learn that better than me. But my mind is centered in Nclex, and Nclex uh, doesn't use to make so complicated question that probably you need to consult with the supervisor, and maybe the supervisor is going to call the legal advisor of the facility to take the decision because it's so complex, this scenario. So don't worry, forget it. What you need to know that somebody that is intoxicated cannot live against medical advice because it's not in his or her mental capacity. Okay, but yes, a proxy could probably, probably, okay, being authorized to take responsibility for the intoxicated client, but need to be designated, need to be have a designated proxy, and 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 that's it. Okay, but the important here is who can live against medical advice. Adult in his or her mental capacity is the same as who can sign consent. Adult with few exceptions and um, um, in their mental capacity. So this client is not in his mental capacity. 1 hour ago, drank a complete bottle of vodka and is having hypoglycemia, which also altered the mental status. If you allow this client to live and something happens to this client, you are liable. You cannot allow this client to live. Um, Client who is hearing voices, a voice command to kill a coworker. This is an indication for commitment, for involuntary commitment. So this client cannot be left to allow to live. Why? Because is is not in his mental capacity. Is having, okay, is a risk for others, has a homicidal risk, and this is one of the indication of Baker Act. Is one of the indication of commitment. So you cannot allow this client to live. Client diagnosed with bipolar 1 mania, who has not eaten in the last 5 days. 5 days without eating anything. This client is a risk for him or herself, and is starving, and for that reason is with a psychosis, and the psychosis is decompensated, so is not in his or her capacities to live against medical advice. A decompensated psychosis in this scenario cannot live against medical advice. It's not in his or her mental capacity. And then we have a 70-year-old client, an old client, with chest pain and ST elevation in the EKG. So apparently is having a myocardial infarction. But they don't say anything here that the client is not in his mental capacity. Okay? He's 75 years old, but it doesn't mean that he's out of his mind or her mind. So this client can live against medical advice, even having a myocardial infarction. Which one, this is not a question, but which one is the responsibility in client A and client E? Your first responsibility is to educate, is to make those clients aware of the consequences of living against medical advice. And after you explain and you verify that the client understands, is when you can allow the client to sign, okay, the against medical advice discharge. And you need to document that you did this education, this education. And even other responsibility that you have, you need, before the client leave, to contact the provider, I mean the physician. Because even if the client is living against medical advice, the physician will order in the pharmacy medication to mitigate, to make the less severe possible the consequences of living against medical advice. There is nothing wrong in that. It's not true that the physician don't give indications or prescriptions to clients living against medical advice. Has been tested. You should contact the doctor because the doctor probably will provide outpatient recommendations. And the last is that insurances, the third uh, uh, payer, uh, don't punish the client for living against medical advice. They cannot do that legally. So they cannot deny, okay, covering the expenses of the client because it's living against medical advice. Those are the elements of medical living against medical advice or discharge against medical advice that we need to know for legal question, simple question. Don't complicate the question. The legal questions that we have in Nclex don't require calling the hospital lawyer, the legal department. It's not necessary. Are very basic, like those examples that are mentioned here. The same as who can sign consent. And simple. Don't complicate. Don't create difficult scenarios in where you need to consult with a supervisor or with a legal department because it's too complex. Okay. Right. Uh, those are not the classical question in your English. Basic question, yes, like this. The nurse observed the asthmatic client using the peak flow meter and obtaining a measurement of 80%. Okay, remember that the client should do that 3 times and then take the best of the measurements. So the best of the 3 measurements done at the moment is 80%. The clients will blow in the peak flow meter device 3 times and is going to choose the best, okay, of the 3 determinations. So the best determination was 80%. You should know that 80% is normal. From 80 to 100% is normal. The client is okay. The client is having a good, you know, movement of air in and out. The client has a normal ventilation. There is no bronchospasm. But the question say which client's statement requires follow-up. So what is wrong? I must take the Sapphire Leucast tablet 1 hour before a meal. Sapphire Leucast is a leukotriene inhibitor. Leukotriene is something produced by the white blood cell, by the leukocyte. This something, this something produces inflammation. It's part of the immunity, it's part of the defense system, and produces inflammation. In asthma, there is inflammation in the lining of the bronchi. So we use anti-inflammatory medications like glucocorticoids, yeah, inhale glucocorticoids, okay, and leukotrienes inhibitors to decrease the inflammation of the lining of the mucosa of the bronchi. This is a treatment that is around the clock, is taken every day in asthmatic clients to prevent, okay, the asthma attack, the inflammation and the bronchoconstriction. Because it's taken every day, the Sapphire Leucas should be taken with empty stomach. And the best moment of an empty stomach is 1 hour before meal. So 1 hour before a meal is considered empty stomach. So is correct. Sapphire Leucas should be taken with empty stomach. The other one is the Monteleucast. It's the same family. The difference with the Monteleucas is the Monteleucas is not affected by the meals, can be taken independently with meal or with empty stomach. Monteleucas uh, um, produces sleepiness. It produces, a sleepy condition. It's like, I don't know, some medication that make you sleepy. So it's better to be taken at night for that reason. Is a comment of the Monteleucas. This Monteleucas and this Sapphire Leucas have been in Nclex several times. It's a very commonly prescribed medication for respiratory inflammatory problems, you know, and it is correct. So it doesn't require follow-up. I must take 2 puff, 2 deliveries of albuterol as a rescue inhaler. And the question is why? If the client is not having bronchospasm, is the meter, a peak flow meter is normal. So probably this is the problem. I should wash my bed linen with hot water. Why they must do that? Because the dust mite. The dust mite is a microscopic insect that tends to live in the mattresses, pillows, and the linen that should be eliminated, not eliminated, cannot be eliminated, can be minimized the amount, frequently washing the bed linen with hot water and drying them in the hot cycle of the dryer. Because the dot mite is part of the allergens that precipitates the inflammation of the bronchi because they become airborne and penetrates in the bronchi, producing inflammation of the lining of the bronchi. So decreasing the amount of dust mite in the house will improve. So it is correct. It doesn't require follow up. I am allowed to drink coffee and tea. There is no contraindication of drinking coffee and tea, I mean caffeine, in this client. The client that is taking theophylline, theophylline, okay, is the one that should not be drinking too much caffeine because theophylline and caffeine have, potentiation. It has this potentiation of the toxic effect. And the client's not taking theophylline. So there is no contraindication. So absolutely, the answer is B. There is no need of using the rescue inhaler if the client is not having bronchospasm. It is used when there is symptoms, when there is bronchospasm. It's an unnecessary dose of albuterol. The nurse suspects that hepatotoxicity is developing in an African American client, a black client, who is on a statin. In what area of the body should the nurse assess for jaundice? It's a classical question of assessment that in black clients, the correct site to assess for jaundice and for anemia is in the buccal cavity. Eye sclera, palms, and salt and eye conjunctiva can have pigmentation that makes it difficult to evaluate paleness, cyanosis, and jaundice. But the oral mucosa is going to be the best site to evaluate those changes in the coloration of the mucosa and the skin that are important for diagnosis. This is a classical question of assessment that all we know. Which statement illustrates a correct understanding of positive and negative symptoms of schizophrenia? We need to know that the positive symptoms are symptoms that are incorporated, added by the disease, where are symptoms that were not present before the disease and appears when the disease developed, the schizophrenia. Well, negative symptoms are um, skills, characteristics that are lost by the disease, where characteristic skills of particularities of the personality that were present before the disease and then are lost when the disease appears. Okay. Uh, a detail that is very useful when you have the letter A before a word is because the client has lost the word, even if you don't know what the word means. So the students that are smart and want to have an easy rule for the loss negative symptoms of something, look for the A word, no? The A word, yes. And it's important. It's useful. The problem is that sometimes there are some negative symptoms that don't follow this rule. There are negative symptoms that don't have the A, okay, word, okay, but it's useful. So, for example, when we have anhedonia, that have the A, is because it's lost. The hedonism is the capacity of enjoying pleasures. There are stuff that produce pleasure. Everybody knows that. And uh, when you lose the capacity of enjoying pleasures, then it's anhedonia. But because it's the loss, it's a negative symptoms, and here it say that it's a positive symptom, which is incorrect. A volition. Volition is initiative, motivation, what moves you to do something. Yeah, the is the opposite of apathy. Yeah, so evolution is the loss of the capacity of initiate actions. Okay, and it is a negative symptom. So I like this option because it is a negative symptom. Okay, uh, is a negative symptom. I like this option. I'm looking for the correct description. Thought blocking is when the client, because the schizophrenia, says that cannot think about something or an area because feels that something or somebody is blocking the thought in the mind. So thought blocking is the loss of capacity of some kind of thinking. So it is a loss. It is a negative symptom. So it is wrong. It's described here as positive. And hallucination, you gain, you gain something you didn't have before. So you start seeing or hearing things that were not present before the disease because are things that are, don't exist. So it's described here as a negative symptom when the hallucination is a positive symptom. So the best answer is B. Trying to understand and to master positive and negative symptom of schizophrenia because it's frequently tested more or less this way in your Nclex. Uh, this is a new generation question that says the nurse working at the outpatient pediatric clinic is performing an admission assessment for a 7 years old child who is accompanied by their parents. Uh, the child reports right ear pain for 3 days. The nurse documents the following assessment findings. Client reports right ear pain for 3 days, described as constant, aching, non-radiating, denies dry mucous membranes, eye drainage, so denies all this stuff, no? Denies nasal drainage or throat pain. The oropharynx is pink, moist, with not redness, swelling, or exudate. Reports no sick contacts and has been attending full days of school. Reports swimming daily for the past week. Denies neck stiffness, no swelling on the neck or swollen lymph nodes. Denies cough, wheezing, difficulty breathing, long sounds are clear. Tenderness noted on palpation and manipulation of the right auricle with ear canal erythema. No discharge, left auricle non-tender. Immunizations up to date. But the question is very simple. The question says, complete the following sentences. The nurse determines that the child is experiencing otitis externa. So the nurse diagnoses otitis externa. Based on what? Based on 1, 2, and 3. So we need to select based in which finding we support the diagnosis of otitis externa. For one, no sick contact, ear pain without fever, attends full school days, left auricle is non-tender to manipulation. So obviously, the best option here is that you suspect otitis externa because there is pain in the ear without fever. It is usually the otitis externa is not producing fever. So I move that here. The second, denies neck stiffness, immunization up to date, swimming daily for the past week, lack of nasal drainage or throat pain. Obviously, this is a risk factor for otitis externa. That's why it's also called the swimmer ear. Yeah. So it is a risk factor, okay, that support the diagnosis of otitis externa. So I move that to 2. And here, the nice cough, no lymphadenopathy, which is a lymph node, tenderness on manipulation of right auricle. Long sounds clear to auscultation bilateral. So the other thing that here supports otitis externa is pain when we pull or manipulate the auricle of the affected site. So it's a silly question, but the report that I've been having about this new generation clinical judgment questions are very simple, are very, what color is the white horse of Napoleon? I have here more information, but it's not, was not very important. No fever, no problem. Okay. Next question. A client with chronic anxiety and migraines has been prescribed citalopram. Citalopram is Lexapro, is an SSRI. SSRI, a selective serotonin reuptake inhibitor. Which of the following statements represents a correct understanding of the teaching of this medication? So what is correct? Improvement will be evident within the first week of treatment. This is incorrect. It is too soon. You need to explain clients that this kind of medication produce effect after a while, usually 3-4 weeks of initiated. So this is not understanding, is not correct. The client may experience sexual dysfunction. You need to know that the SSRIs produce with frequency sexual dysfunction. Which one? Decreased libido, impotence in males, and lack of orgasm and orgasmia, okay, in the client. So you need to warn the client that is one of the prices to pay, okay, to improve other symptoms. So it could be the right option. Phenelzine, so it is assuming that the patient was taking phenelzine previously, must be continued as ordered. Phenelzine is a MAO inhibitor. A MAO inhibitor cannot be combined with SSRIs. So it is incorrect. Okay, it is unacceptable. It's very risky, can produce hypertensive crisis. And as a matter of fact, if the client was taking phenelzine, MAO inhibitor, as stated in this option, the client needs to wait 14 days, 2 weeks, without taking the phenelzine to initiate the escitalopram. Needs a washout period, okay, to initiate, because it's very risky to combine the two medications. Sumatriptan can be used if experience a migraine attack. Okay, I review this option. In yes, sumatriptan can be used with minimum interaction with the SSRIs because they are not described, okay, that precipitate serotonin syndrome or something similar. So can be taken. So obviously the best answer of this question should be the sexual dysfunction that is well known, that is produced by the SSRIs. Which Eric Sams psychosocial developmental task is for a 9-year-old child. This is school age. and school age is industry versus inferiority. So it is a very straightforward, okay, question. Um, let me share with you which question is not frequent. Ericsson is not frequent in English. It's very rare. But some questions have been. Um, which is missing here. I have missing here integrity versus despair. This is the stage in which I am in this moment of my life. Integrity versus despair. Identity versus confusion is the adolescence. It is an old person. This is an adolescent. Initial versus is the preschool. Huh? The preschool, the terrible preschool. Preschool. Um, Industry is school age. We already say that. School age. Autonomy versus change doubts is toddlers. Toddlers. Okay. What is missing here is the young adult. The young adult. The one that is not teenager but is less than 30. The young adult. Young adult. This is how you call that? I always forget the name. Isolation versus intimacy. Okay, intimacy versus isolation. And the middle age adult is generativity versus stagnation. If I say that I have a 50 years old male alcoholic that is admitted for alcohol withdrawal and is not visited by the spouse, by the wife, not visited, or his children, because they don't want to know anything about him. In which stage is this scenario? Is the way that Nclex made the question. Okay, I noticed that you don't like that too much. Okay, 50-year is a middle age adult that should be between generativity versus stagnation. What is generativity? Is to generate uh, stuff that builds your life. What is generativity? Generativity has an important component that is economic. So you already get your license, you already find a job, start working, start making money, start saving money, buy a house, buy a car, or maybe initiate a retired saving account. Maybe you save for your children to go to college, and you develop expertise in your profession as a nurse, and then your curriculum is is solid. So now you can apply to other jobs that have better pay or you like the most. Um, and then you build a family, you raise your children. Your children are the, the result of your work, of your yes, of your dedication. So you are generating, okay, stuff, good stuff. What is stagnation? You are stagnant. So you don't prosper in your profession because you become, I don't know, maybe in this case, an alcoholic. Yeah. and you are fired, maybe your license is suspended because DUIs and etc. etc. And then your family, you behave so bad with your family doesn't want to know anything about it. So this client in this situation is in stagnation. It's to make you understand how it's tested on Erickson in Nclex. If I say I have a 78 woman who is the single mother of 3 children, and she raised the 3 children working as a maid, okay, as a maid, yeah, working very hard as a maid. But the 3 children went to college and graduated. So one is a lawyer, the other one is a nurse, and the other one is, I don't know, an accountant. In which stage is this woman? A single mother that worked all her life with as a maid, never passed beyond, okay, third, fourth, fifth grade, and has 3 children that are professionals. In which stage is you think is this woman?
Integrity versus despair.
But is in integrity or in despair? Because you need to choose now between the two verses. Yeah, isn't this okay? This is the stage, the integrity versus is the stage that I am in this moment. All people, we are in this stage. This woman, try to think a little because this was exactly the example that was in English. An old lady, single mother, working all her life very hard, made hmm, sometimes humiliating work, but she raised 3 children and sent the 3 children to college, and the 3 children graduated from college. How do you think she feels? Proud of herself or in despair? Is showing an integrity of her personality, is happy with what she did with her life, or is she saying, no, if I were born again, I never should have more children, I never would have children, I never would. Obviously, this woman should be very proud of herself and is in integrity. So this is the way that is tested in English. Another question that I know in English: a 70 years old man who is admitted after an attempt of suicide. So obviously is in despair. Now, do you understand how is tested Erickson in the English?
Yes.
So is a very a practical approach in which is not so much as memorizing, which are the different stages. Nevertheless, I suggest you memorizing that because are beautiful, are beautiful. Okay, as Professor Monal to to refresh that on you, um, because okay, this is interesting. Okay, versus or different from success versus failure. Of the different stages. I love Erickson. I like Erickson because after I studied Erickson, when I studied nursing, I realized that it's true. I analyzed my own life and the life that people near me, and it's true, more or less. Okay, we are going through those stages of psychosocial development. Okay, the nurse has been assigned to the ophthalmologic surgical area. So you floated to the surgery, uh, eye surgery area. What recommendation is adequate to be given to a client who underwent cataract surgery and is going to discharge home? Okay. What is the correct teaching? Okay. Uh, in those cases, sleep only supine or lateral on the operated side with two pillows. Okay, if the client has surgery in one eye, in one eye, the client should be sleeping supine, me parece un extraterrestre, supine, okay, supine, uh, with elevation of the head. So supine with elevation of the head in semi-fowler. But if it's sleeping lateral, should not be sleeping over, okay, the surgical side. Should be sleeping on the non-surgical side. So this is incorrect. So it is not a good recommendation. Practice coughing and deep breathing every hour. Client that has surgery in the eye should not do coughing. Okay, coughing is not good for them. And because the increment of the intraocular pressure could produce distortion, okay, of the surgery and displacement of the lens. Don't tie your shoelaces by yourself. This is a correct advice. Don't tie, okay, your shoelaces by yourself because it implies, okay, bending over, okay, bending over, and it is going to increase the intraocular pressure. It's no good. So it is a good advice. Keep the protective eye shield in place at all times. Eye shields are like a special of cups, plastic cups that are placed over the eye with a tape at night only. Is to prevent accidentally rubbing or hitting the eye while you are sleeping. So the eye shield is placed only at night, only at night. So the right answer, the right recommendation is don't bend over. The nurse is responsible for the care of a client with a femur fracture placed in box traction in preparation for surgical open reduction internal fixation. So it's going to have orthopedic surgery to repair the fracture the next day. But meanwhile, um, wait for the surgery is going to be placed, okay, in box traction, which is an skin traction. Which interventions should the nurse take cerebral apply? And I have several interventions. The weight must hang freely over the edge of the bed. The bed is placed in Trendelenburg position. The foot of the bed is elevated. The head of the bed is elevated. A pillow is placed under the knee region. The client is turned from supine to lateral every 2 hours. A pillow is placed between the knees when turned lateral. The ropes or the rope is kept free of knots and entangles. So I suggest in that case, let me see, seeing this video. Let me see, if I can project this video. What happens with the video? Okay, it's here. No? I always get. Ah, it's only one click. Okay. It's too small. Okay, let me see if I can. It's too small. Just a moment, guys. Let's make it bigger. Okay, much better. Okay, notice that there are many questions in Nclex about box traction, which is the most commonly used skin traction. And the only way of being able to answer all those questions is to understand what is box traction. Understand that this client has a fracture or a bone, and the bones overlapping, are overlapping one over the other, okay, because the fracture. And there is an spasm, a contraction of the muscles that are around the muscle. So for that reason, the client is placed in traction to overcome the, the spasm, the contraction of the muscle. This is going to uh, align the bone fragments, is called reduction, decreases the pain, and stabilizes the fracture, preventing the movement. So it's going to be seen more or less like this. Notice how the feet, how the feet of the bed is elevated to prevent the client from sliding by the pulling action of the ropes of the weight. Okay. Okay. The supplies are the boot is a form of boot that is going to be wrapping the leg, and is going to be uh, connected, attached to the rope that are going to be pulling the leg. Okay, pulling the leg. You need a weight. Usually it's 5 pounds. Okay, 5 pounds is the most common, okay, amount of weight used in the traction, and of course rope. It's important that when a client has a hip fracture or femur fracture, the extremities shorten and the foot is dropped laterally in supination. It happens when there's a fracture. So this is more or less the position of the leg. But when you do the traction, always the legs should be aligned. So the separation between the hip is the same separation between the knees and the same separation between the ankles to keep the legs aligned, not open, nor closed, not in abduction, abduction, nor in neither in abduction or adduction. So neutral. After the surgery is when we keep the legs separated. I mean, in abduction with a pillow between the legs, with an abductor pillow. But before the surgery, when the client is in traction, the legs should be straight and aligned side by side. But after the surgery, we keep the legs separated. I mean, in abduction, in abduction. It's necessary to elevate, okay, the foot of the bed, because otherwise the pulling action of the weight will pull the client and slide the client toward the bottom. It is called counter traction. Of course, those models change. It is a model that have these people. But look how they tied the ropes to the boot. The boot is disposable. The ropes are disposable. The other elements are not disposable. They secure that with nuts, and they tape that to prevent people from untying the nuts, okay? Because it should be all time in traction. So they thread the rope through the pulleys. Okay, those wheels that you see here are called pulleys. Okay, and those are going to change the direction of the traction. Okay, pulleys should be totally free of knots or entangles to prevent. Okay, so this is how they put the fracture leg inside the um, the cushion. Okay, boot. Notice that it's not tight. There is no need of keeping that tight. This is the weight, 5 pounds. That should be all times freely hanging. Never should rest on the floor or on the bed or in a chair. Never. If the client needs to be transported, if the client needs to be transported, there is no problem in having the weight, dangling dirt, okay, swinging dirt, because the pulley prevents this movement to be transmitted to the traction. And yes, there is a risk of DVT, and that's why those exercises are recommended, okay, and any other doctor's order to prevent DVT in this client. It's important, very important, to notice that the heels are the most susceptible part, the heels, of developing pressure ulcers, because are in contact, supporting the weight of the client that has elevated the foot of the bed. Okay, uh, uh, and are at the risk of pressure ulcers. For that reason, uh, this boot is very cushioned. Okay, but it's okay to place a pillow under the leg, never under the knees. When we put pillows under the knee, we make pressure in the popliteal area, which is this cavity that is in the leg behind the knee, where the deep veins becomes very superficial against the bones, okay, the tibia. And for that reason, pillows should not be placed behind the knees because promotes DVT. But pillows could be placed here under the leg to have the foot floating, so never the heel touching the mattress. Offloaded heel. Okay, offloaded heels called. Every shift you check for skin integrity, that the ropes and the pulleys are working freely and the weight is freely hanging there. It's nice. Notice this. While on traction, the client must be changed position every 2 hours to prevent sacral pressure ulcer, etc. So we place a pillow between the legs and we turn the client to lateral. This is where it is documented in the electronic, okay, and then when we discontinue that. Okay, so now that we saw the video, let's see if we can answer better those questions. The weight should be hanging freely over the edge of the bed. Yes. The bed is placed in Trendelenburg position. No. Trendelenburg position is this. Yeah. The foot of the bed is elevated. Yes. The head of the bed is elevated. There is no problem in doing that. You can have the head of the bed in semi-fowler, yeah, for comfort of the client, and then the foot of the bed elevated, you know? So it's more or less being the clinical bed this way. So the patient is going to be comfortably, okay, comfortably, okay, resting here. Okay, you understand? So I don't see problem in elevating the head of the bed because it makes the client more comfortable. Okay. A pillow is placed under the knee region? No, because it promotes DVT. The client is turned from supine to lateral every 2 hours? Yes. A pillow is placed between the knees when turning lateral? Yes. The rope is kept free of knots and entangles? Yes. So notice how you can find, okay, information in YouTube, okay, in YouTube that help you, porque no se me help you to understand stuff that sometimes, because you never saw that in real life, becomes a little cryptic, a little difficult to understand. Okay, obstruction. A client with left-sided paresis, so is weak in the left side, uses a quadripod cane. Quadripod canes are canes that are in the tip has like a square that four little legs, no, four little legs, and are more more stable for the client. Yeah, more stable for the client. I think that you've seen them. It's very frequent to see clients that have an important difficulty using this kind of cane. Which of the following illustrates appropriate use of the quadripod canes? And we have the following options. Assist the patient, you as a nurse or the CNA. Assist the patient on the right side when ambulating. So put yourself in the right side when ambulating. It is incorrect. We should be placed when helping the client to ambulate in the weak side, and the weak side is the left. What is the rationale to be at the weak side? If the client tends to fall, is falling toward you, and you can break the fall, sliding the clients down to the floor. If you are placed in the strong side, the client will fall away of you, and then it's going to pull you, and you both are going to fall. That's why we need to be assisting the client to ambulate, placing ourselves in the weak side. Ask the rehabilitative department to change the cane into a single cane, not this cane, sino a single cane. Okay, a single cane for proper balance. It is incorrect. This quadripod cane provides more balance, more stability than the simple, okay, regular cane. So it is a nonsense. We don't need to ask to change that. The same way as consulting the physician for possible change of assisted device. Which one? Wheelchair? Walker? This is enough for this client. So I don't see the reason for that. So the best option needs to be the last. The quad cane should be 6 inches from the unaffected side. So the cane should be held by the right side, because the paralysis, the weakness is in the left, in the unaffected side, and the hand grip, the top of the cane, should be labeled with the greater trochanter, with the hip. This is correct. This is the height of the correct height of the cane. Cane is also, and crutches, frequently tested in English. Which statement illustrate incorrect understanding about Montelukast? We already talked today about Montelukast because we already talked about Sapphire Leucast. It's the same. I will continue to take this medication even if I'm feeling okay. It is correct. And we are looking for the incorrect. Okay. So it is correct. It is correct. So no problem with this. Remember that this kind of medication is to prevent inflammation, and is taking around the clock, even if the client feeling okay. I will take these ones in the evening with or without food. Okay, no problem. good to have that in the evening because it produce somnolence, and there is no problem with the food. This is correct, so there is no problem. Taking the medication during an attack, it is incorrect. Those medications are not taken during an attack. Okay, and the last say this is an anti-inflammatory medication. It is correct. So this is the incorrect statement. And the last says a nurse is reviewing a case of iron deficient anemia with the provider and a possibility for an iron preparation to be given by the parenteral route. Guys, parenteral route is with a needle, with a shot. Okay, can be subcutaneous, not iron, but any parenteral route could be subcutaneous, intradermal, intramuscular, or intravenous. But in that case, for iron can be intramuscular or intravenous. The nurse plans to give the medication by which the following route. So this is incorrect. Oral is not because this is enteral, not parenteral. Deep gluteal intramuscular injection using Z-track, this is correct. Must be the answer. Let's see the others. Intramuscular in the deltoid. No, we don't put iron in the deltoid. Okay. Subcutaneous, no, we don't give iron subcutaneous. So the answer is B. Sorry, guys, but those are the questions that I have for you today. Do you have any questions? Or have something that you want to discuss?
No, it's fine.
Are you okay? Okay. Well, um, I wish you, if you are still taking finals, is enjoying the final week, I wish you the best. And if you are ready for your Nclex, I hope that you pass the first time. Bye-bye, guys.
Thank you, Professor.
Thank you.